Okay, now we will start with our second part of trauma from occlusion. Up till now, in the first part, we have studied what is trauma from occlusion. So, trauma from occlusion is the injury. It's the injury which is caused due to the excessive occlusive forces when the periodontia fails to accommodate these forces because of the reduced adaptive capacity. Okay, so we have seen that there are two kinds of trauma from occlusion: primary trauma from occlusion and secondary trauma from occlusion, or it may be acute or chronic trauma from occlusion. Okay, now we will see that what happens when the injury has occurred. So when the injury occurs, the tissue response occurs in three stages. It is injury, repair, and adaptive remodeling of the periodontium. It occurs. So under the forces of occlusion, the tooth rotates whenever a force is applied. Under the forces of occlusion, a tooth rotates around a fulcrum or the axis of rotation, which is single rotate tooth is in the area between the middle third and the apical third, and in the multi-rotate tooth, it is in the percussion area. So when a force is excessive occlusion or when a force is applied to the tooth, this creates an area of pressure and tension. So this is the force which is being applied when a fulcrum is being applied. It to a tooth, it creates two areas of pressure and areas of the tension. So different types of lesions are produced by different degrees of pressure and tension. So in these areas, different types of lesion exist depending upon the severity of the forces. If the jiggling forces are exerted, these different lesions may coexist in the same area. It means if there is a unidirectional, the forces are acting from one direction, so two specific areas will form. But if there are jiggling kind of forces that are acting from all the directions, so in the same area, there may be areas of pressure and tension. Similarly, on the opposite side, there will be area of pressure and tension. So this is meant about this statement that if jiggling forces are exerted, these different lesions may coexist in the same area. Now, what happens? There are three different situations which we can assume. If the pressure is slightly excessive and the tension is also slightly excessive, the fulcrum is applied, this area is the pressure side and this area becomes the tension side. This is the normal tooth. Okay, this is the tooth. Now, when the pressure is applied, now the tooth, what happens? This is the pressure side. Here, the uh, it will cause resorption of the bone. So osteoclast will come and there will be resorption of the bone. And when there will be resorption of the bone, there will be resultant widening of the periodontal ligament space. Now, what is happening in the tension side? Here in the tension side, there is the because of the force, the tooth slightly shifts towards the pressure side. Okay, and there is space is created because of the pressure. Okay, so slightly excessive tension side, it causes elongation of the periodontal ligament fibers and apposition of the alveolar bone. When there will be apposition of the alveolar bone, now this periodontal ligament space will be maintained. Both the directions. Now, in the areas of pressure, what happens to the blood vessels? The blood vessels are numerous and are reduced in size. And in areas of tension, they are enlarged. Okay, so this is situation number one when there is slightly excessive pressure, slightly excessive tension. Now, when there is greater pressure and greater tension, what happens when the force is being applied? Okay, the focus. And we know this is the pressure side and this is the tension side. Now the pressure is more, slightly excessive. Now it is greater pressure. Second part is greater pressure. It produces a gradation of changes in the periodontal ligament, starting with the compression of the fibers, which produces areas of hyalinization. There will be compression of, there will be what? There will be uh, uh, compression of the periodontal ligament fibers, which produces areas of hyalinization. Okay. No subsequent, which will cause subsequent injury to the fibroblast and other connective tissues, and which may lead to the necrosis of the area of the ligament. Vascular changes are also produced. within 30 minutes. Now, what we can see, how many kinds of what kind of vascular changes are seen within 30 minutes. Means immediately within 30 minutes, there is impairment and stasis of the blood flow. There will be the impairment and stasis of the blood flow will occur. At 2 to 3 hours, blood vessels appear to be packed with erythrocytes. So, in the pressure side, what will vascular changes get in there? There will be impairment or stasis of the blood flow. In 2 to 3 hours, the blood vessels appear to be packed with erythrocytes and they start to fragment. And between 1 to 7 days, there will be disintegration of blood vessel walls and release of the content into the surrounding tissue. Okay. In addition, increased resorption of the alveolar bone and resorption of tooth will also. So now all this will lead to increased resorption of alveolar bone and resorption of the tooth surface. Now severe pressure and severe tension. When that was excessive, greater pressure. Now severe tension and severe pressure. Now pressure severe enough to force the root against the bone. If the force is still increased and it is becoming severe, now what will happen? If the second part there was compression of the peduncle fiber. Now there will be enough to cause pressure severe enough to force the root against the bone. The root of the tooth will be forced to rest against the bone, and it will cause the necrosis of the peduncle ligament and bone. And the bone resorption, the bone is resorbed from the viable peduncle ligament adjacent to the necrotic area and from narrow spaces, and this process is known as undermining resorption. So now, boys, where from the bone is resorbed? Viable peduncle ligament adjacent to the necrotic area and from the narrow space. So this is a diagrammatic tabular representation or chart-wise representation of what happens when is extreme force. In the pressure side, where will be total compression of the peduncle ligament fibers, occlusion of the blood vessels will be there, hyalinization will be there, and the no immediate tooth movement like this will cause undermining tooth resorption so as to maintain the space. Now, tension side, there will be overstretching of the peduncle ligament, rupture of the blood vessels will occur, and hyperemia of the gingiva, ischemia, and pain, and it will cause late tooth movement. And now, stage 2. Repair occurs constantly. Repair occurs constantly in the normal periodontium. Okay, when the periodontium undergoes an injury, at the same time, hand in hand, the repair also starts. The repair occurs constantly in the normal periodontium. And trauma from occlusion stimulates increased reparative activity. The damaged tissues are removed and the new connective tissue cells and fibers, bones, and cementum are formed in order to restore the injured periodontium. Forces remain traumatic. Forces will be called as traumatic as long as the damage produced exceeds the reparative capacity of the tissue. Now, when the bone is resolved by excessive occlusion forces, the body attempts to reinforce the thin bony trabeculae with the new bone. So, because of the excessive occlusion forces, body there occurs thinning of the bony trabeculae, and there is a formation of new bone. And this attempt to compensate for the loss of the bone is called as buttressing bone formation. And it is an important feature of the reparative process associated with trauma from occlusion. So, what happens when the bone is resolved because of the trauma from occlusion or the excessive occlusal forces? The body now tries to repair it. Now, in that process, it attempts to reinforce the thin bone trabeculae with the new bone. And this process is known as buttressing bone formation. And it is an important feature of the reparative process or the repair process associated with trauma from occlusion. It also occurs when the bone is destroyed by inflammation or osteolytic tumor. Okay? So, buttressing bone formation occurs when this buttressing bone formation occurs within the jaw. It is called as central buttressing. And when the bone surface, when it occurs on the surface of the bone, it is called as peripheral buttressing bone formation. So, during the central buttressing, the endosteal cells deposit new bone, which restores the bony trabeculum and reduces the size of the narrow space. Peripheral buttressing occurs on the facial and lingual surfaces of the alveolar plate. Depending on its severity, peripheral buttressing may produce severe shelf-like thickening of the alveolar margin, which is referred to as clipping, or pronounced bulk in the contour of the facial and the lingual. So, an attempt of repair, what happens if this repair or the formation of the new bone occurs within the mandible, inside the mandible, it is known as buttressing bone formation. And when this occurs on the facial and the lingual surfaces, it is known as peripheral buttressing. And when peripheral buttressing occurs, it may lead to formation of shelf-like thickening of the alveolar margins. And when this occurs, it is known as slipping, or it is a pronounced bulge or contour which occurs on the facial and lingual bone. So cartilage-like materials sometimes develop in the periodontal ligament space as an aftermath of the trauma, and the formation of crystals of erythrocytes have also been. So in the repair phase, we have seen that after injury, whenever there is an injury, the mandible or whenever there is an injury, the periodontium tries to repair itself, and in this process of repair, it leads to formation of the new bone. When this new bone formation occurs inside the mandible or within the mandible, it is known as buttressing bone formation, since polytrabecular and new bone is formed. And when this repair occurs on the facial and lingual surfaces, it is known as peripheral buttressing. Now, peripheral buttressing, when depending on the severity, if there is it may cause lipping formation, which occurs on the ridge of the alveolar margin of the bone. Okay. Now comes the third stage, which is adaptive remodeling of the periodontium. Now what happens if the repair process, if trauma from occlusion, the forces are much, and the repair process is not able to keep pace with the destruction which is being caused by the occlusion. So in this case, the periodontium remodels itself. अपने आप को थोड़ा सा remodel कर लेता है, अपने आप को थोड़ा shape change कर लेता है. The periodontium is remodeled in an effort to create a structural relationship in which the forces are no longer injurious to the tissue. So, if the repair process is not little bit slow as compared to the destructive process, now what happens? Body tries to protect itself. In that case, the periodontium अपने आप को it remodels itself. मतलब फिर से वो अपने आप का structure थोड़ा सा change कर लेता है. In so that its structural relationship बन जाए ऐसी कि जो forces are no longer injurious to the tissues. This results in, now what happens? How does it happen? This results in the widening of the periodontal ligament space, which is funnel shaped at the crest. We have seen in the radiographic picture there is funnel shaped bone resorption at the crest. So there is a funnel shaped crest resorption. Angular defects are seen, but there is no pocket formation. And the involved teeth become loose. Increased vascularization has also been reported. So the injury phase shows increased areas of resorption and decreased bone formation. Repair phase demonstrates decreased resorption and increased bone formation. And after adaptive remodeling of periodontium, resorption and formation return to normal. Now we will talk about the relationship between the plaque-induced periodontal diseases and trauma from occlusion. Okay. So early investigators and clinicians have assigned that they say that there exists an important role of trauma from occlusion in the etiology of the periodontal diseases. Okay. So the accumulation of the bacterial plaque. Now let's read about it. What does it say? The accumulation of the bacterial plaque that initiates gingivitis and results in periodontal pocket formation affects the marginal gingiva. But trauma from occlusion occurs in supporting tissues and does not affect the gingiva. So accumulation of the bacterial plaque which initiates gingivitis and which if further proceeds leads to periodontal pocket formation affects the marginal gingiva since which till the gingivitis. But trauma from occlusion occurs in the supporting tissue and does not affect the marginal gingiva. The marginal gingiva is unaffected by the trauma from occlusion because its blood supply is not affected, even when the vessels of the periodontal ligament are obliterated by excessive occlusion forces. So it says that when unless when till the time the inflammation is occurs, yeah, or it is confined to the marginal gingiva, the trauma from occlusion does not has any effect on it. But when the trauma from when the inflammation now proceeds and gingivitis become periodontitis, now the inflammation has reached to the supporting structures of the tooth, alveolar bone, periodontal ligaments, cementum. Now the occlusion, now this trauma from occlusion will have its effect. Okay. Now Glickman called it as so Glickman gave a concept which is known as Glickman concept, and Glickman divided this zone into this tweak into two zones: zone of irritation and zone of co-destruction. Okay, so let's talk about Glickman concept. Glickman and Mueller proposed the theory in the early 1960s that a chromatogenic occlusion may act as a cofactor in the progression of the periodontal. Okay. This theory is known as co-destructive theory. So Bateman concept said if periodontitis is present, then a trauma from occlusion may act as a cofactor in the spread of inflammation. Newton in 1965 and 67 claimed that the forces of an abnormal magnitude are acting on the teeth harboring subgingival plaque. Then the allay of the spread of plaque-associated gingival lesions can be altered if this lesion reaches to the periodontal supporting structures. So he says the periodontal structures can be divided into two zones. Zone of irritation, which is limited to the marginal gingiva, and the zone of co-destruction means where, and second is the zone of the co-destruction. We will know about it. What does it is formed of? So zone of irritation consists of marginal gingiva, marginal and interdental gingiva, and the soft tissue zone is surrounded by hard tissue of the teeth on the one side, and it has no impact on the occlusal forces. This means that gingival inflammation cannot be initiated by trauma from occlusion, but rather due to irritation from the plaque. So Glickman said uh, the tooth which is harboring the subgingival plaque, if there is gingivitis into or the plaque is contained only till the marginal gingiva, which is known as zone of irritation, which is surrounded by tooth on one side and the surface is soft tissue. Then the trauma from occlusion will have no effect in the spread of inflammation, only the subgingival flora will have its effect. Okay. Now, then it says when the gingivitis proceeds to periodontitis, now, he said there is a second zone which is known as zone of co-destruction. And this zone of co-destruction consists of periodontal ligament, cementum, alveolar bone, and it is coronally delineated by transector and endoalveolar collagen fiber compounds. The inflammatory lesion in the zone of irritation can, in teeth not subjected to trauma, propagate to the alveolar bone. While in the teeth subjected to trauma from occlusion, the inflammatory infiltrate spreads directly into the periodontal. Now, in the zone of co-destruction, we have seen that periodontal supporting structures are present: cementum, alveolar bone, periodontal. This lesion is delineated coronally by the fibers transector and the dentoalveolar. Now, it says when this lesion reaches to becomes gingivitis become periodontitis, and if this is not affected by trauma from occlusion, this inflammation or inflammatory path which it will follow will be uh, from the gingiva to the alveolar root and then the periodontal ligament fibers. But if this tooth harboring subgingival plaque and having periodontitis, it is affected by trauma from occlusion, then the inflammatory infiltrate spreads directly into the periodontal ligament. So this showing that is the regular pathway. अगर इन्फ्लेमेशन होता है पेरिडोंटाइटिस हो जाता है तो इन्फ्लेमेशन जो स्प्रेड कैसे रहता है पहले जाता है एल्वियोलर बोन में उसके बाद जाता है पेरिडोंटल लिगामेंट फाइबर बट इफ tooth is affected by trauma from occlusion then it will spread directly into the this is the third it will spread directly into the periodontal ligament. Now, so in conclusion, as long as the inflammation is confined to the gingiva, the inflammatory process is not affected by supporting periodontal tissue, affected by occlusive forces. When the inflammation extends from gingiva into supporting periodontal tissues, when gingivitis becomes periodontitis, plaque-induced gingival inflammation enters the zone that is influenced by the occlusion, that is gingival. So we have understood that Glickman divided the tooth into two zones, zone of irritation and zone of pore destruction. Zone of irritation is confined to marginal gingiva, whereas zone of pore destruction constitutes the periodontal ligament fibers, cementum, alveolar bone. So as long as, if suppose the zone of irritation is not affected by trauma occlusion. When the gingivitis proceeds to periodontitis, what happens? This zone, the inflammation which occurs if the tooth is affected by trauma from occlusion, this inflammatory infiltrate reaches directly to the periodontal ligament, whereas in tooth which are not affected by trauma from occlusion, this inflammation travels from the marginal gingiva to alveolar bone and then the periodontal ligament. So that is Glickman concept. Now, Verhoeven gave a concept. Verhoeven and Glickman both have examined autopsy specimens, but Verhoeven also measured the distance from the subgingival plaque to the periphery of the associated inflammatory cell infiltrate in the gingiva and adjacent alveolar bone surface. He came to the conclusion that angular bony defects and also infrabony pockets occur equally often at the periodontal sites, which are unaffected by TFO and lymphatic dermatitis. So he measured the distance from the subgingival plaque to the periphery where the inflammatory cell infiltrate was present. So he concluded that angular bony defects or intrabony pockets occur equally in the periodontal sites if they are affected or unaffected by TFO. In other words, he refuted the hypothesis that trauma from occlusion played a role in the spread of gingival lesions into zone of pore destruction. So he refused. He said, no, it's not correct. The loss of the connective tissue attachment and resorption of the bone around the teeth, according to Warehouse, exclusively the result of the inflammatory lesion associated with that. Verhoeven said that angular bony defects of infrabony pockets occur when the subgingival plaque of one tooth has reached a more apical level than the microbiota in the neighboring tooth, and when the volume of the alveolar bone surrounding the tooth is comparatively large. So this is Verhoeven concept. Now we will go to the treatment outcomes of trauma from occlusion as proposed by AAP in 1996. Reduce or eliminate the tooth mobility, eliminate occlusion prematurities and preventers, eliminate parafunctional habits, prevent further tooth migration, and decrease or stabilize radiographic feeds. For all these things, you have to take measures, whatever may be required. It may be strengthened. It may be to ask the patient to get rid of the parafunctional habits like breastfeeding and clenching by use of appliances. Okay. So therapy, and now what therapy can be used in primary occlusal trauma? There can be selective branding. If there are high prematurities or there, selective branding will be there. Habit control, orthodontic movements can be used. Night guards can be used. Secondary occlusal trauma, printing may be done. Selective branding and orthodontic movements can be considered. So this is one test which is known as Primitus test, which is done to check the trauma from occlusion. Now, in this, a dampened finger is placed on the labial or the buccal surface of maxillary teeth, and patient is asked to tap the teeth together. In maxillary maxillary together in intercuspation and maximum intercuspation, and then grind systemically into intrusive and intrusive and lateral mobility. If class 1 primitus, there will be mild vibration movement detected. Class 2, easily palpable vibration but no visible movement. Class 3, movement is visible with the nature. So that is all about trauma from occlusions.